Hi guys, Dr. Gillard here once again. Let's do a little dermatology. Today we're going to continue our discussion of dermatophytes. Last week we talked about onychomycosis, which is an infection of super common infection, fungal infection of the nail. And we're going to continue that because there's some other, we're not going to talk about all of them, but Tinea Pedis or athlete's foot is really common, so we're going to talk about that as well. All right, here we go. Dermatophytosis. So often dermatophytic lesions are called ringworm infections, which is not a great word because they don't have anything to do with worms, as we'll see. But they're a very common group of skin disorders which have one thing in common. They're all caused by an invasion of the epidermis only by a fungus, a specific fungus called a dermatophyte. What's so special about dermatophytes? They must have keratin around to survive. They eat it and they live in it. So to be a dermatophyte, you have to thrive on keratin. Simple as that. The invading fungus causes an inflammation in the tissue, which is, again, isolated. It might bump down a little bit into the dermis, but for the most part is a very superficial type of infection. What about the morphology of the lesions? They are classic. They tend to be, they're not always like interdigital type of athlete's foot doesn't look like this, but most of the ones on the body are circular, or at least somewhat circular in shape. The lesion itself is very erythemic. What's that mean? That means it's very red looking and it's quite scaly, but it has a special type of appearance usually, and that is the erythemic and the scaly part of the lesion are more toward the periphery of the lesion, and the center of the lesion tends to be, it almost looks like it's getting better. It's not as involved. So that creates a classic board word kind of buzz called an active border. An active border. And that just means that the worst of the lesion appears to be at the very periphery of it. Let's take a look and you'll see what I mean. So here's a classic active border. It's not a perfect circle, but you could see on the guy's, looks like the elbow here. You could see it's scaly, it's red here, it's a little bit raised. But if you go to the inner part of the lesion, it almost looks almost normal here. So this is the active border of a tinea infection. A tinea infection anywhere on the body except for the palms of the hands, the soles of the feet, the hair, the beard, anywhere on the body like the face, not the beard though. It's called, body means corporis, so it's Tenia corporis. So this is a classic Tenia corporis infection. Okay, as we said, the word dermatophyte is really very broad because it can be many, many different types of keratin-consuming fungi. There's 3 classes or genera that these bugs come from: the microsporum class, trichophyton class, and the epidermophyton class. By far the most common class is trichophyton, and that brings us to the star of the bugs, and that's Trichophytum rubrum, or we're just going to call it T. rubrum. That's by far the major player in this one. All of the dermatophytes, however, they can invade and they can all multiply within keratinized tissue. So that leads to the question, well, is there other tissue with keratin besides the skin? And yeah, remember, there's soft keratin and hard keratin. The nails are made of more hard keratin, so we can have invasions of the nails, causing onychomycosis. We can have invasion of the skin, which is, just invasion of the skin. And we can have invasion of the hair because that contains hard keratin as well. There are 10 main species of dermatophytes in these 3 genera which can all be, they're all dermatophytes. There are about 30 other ones that can occasionally do it. We're not even going to think about those. In fact, we're just going to really focus on Trichophyton rubrum or T. rubrum, because that by far, again, is the most common dermatophyte. That's pronounced Trichophyton rubrum, Trichophyton rubrum. And yeah, this is the same one that causes most types of onychomycosis, or that fungus of the nails. Not all, though. There's other things. Yeast can do that as well. Same with this. It's usually these fungi, but not always. What about the word ringworm? That's the layperson's word. A guy's got a ringworm infection. That's really not a great word to use because you think worm, well, what kind of worm do I have? And you don't have any type of worm. They're caused by fungus infections, so not a great word to use. The most common of dermatophytosis is Tinea Pedis, even more common than onychomycosis, which we talked about last week in class. How do you name a dermatophyte infection? It's really easy. They're all keratin-eating fungi, so they get the word Tenia, or Tenia, and then, so that means they're a keratin-eating invading fungus, and then you use the Latin name for the body part that's affected. So that brings us to a slide which I really like to test on. So here, let's talk about some of these specific dermatophyte infections. So foot means pedis, so Tenia Pedis is an infection of the foot. And we're going to look at there's several different types of Tinea Pedis, like the moccasin type is probably the most common, caused by T. rubrum again. We'll get to that. An infection anywhere on the body or the face, but not of the beard, is called Tenia corporis. I think we said that already. A common one for athletes is an infection down in the groin and private region. That's called Tinea crurus, also called jock itch or jock rot, typically caused by T. rubrum as well. An infection of the dorsum of the hand or foot. Be careful with this one. So we're not talking about the palmar surface or plantar surface. That's athlete's foot. If it happens on the back side or the dorsum of the hand and foot, that gets a new name. That's a different type of syndrome. That's called Tenia manuum. Tenia manuum. If it happens on the scalp, anywhere in the scalp, that's called Tenia Pedis. If it happens, some guys get it in their beards only where there is hair. That's called Tinea barbara or Tinea barbrae. And of course, the infection of the nail, which we covered last week, is called Tinea unguum. Tinea unguum means it's a dermatophyte that has caused the nail infection. It's usually in a nail infection, fungus infection, is called onychomycosis. Tinea unguum is not always the cause of it, though. There are other causes of onychomycosis, like yeast, but they're rare. So usually it's Tinea unguum. Tinea unguum is the way it's pronounced. Did I say that? I think I might have messed that up. But so most of the nails, it's also T. rubrum that's causing the problem as well, but not always. So really, you should call it onychomycosis which means a fungus of the nail or an infection of the nail, until you find out for sure if it is a dermatophyte causing the lesion. Then you can call it Tinea unguum. Does that make sense? What about the transmission? So these dermatophytes have the ability to eat right through the hard keratin of the hair or the stratum corneum, which is super hard, right? It's full of dead cells. Remember the corneocytes? They've lost all their organelles, and they're just basically filled with hard keratin, so they're very hard. Most viruses can't penetrate them, but these fungi can. How do they do that? The fungi actually have an enzyme called keratinase that they release, and that can burrow a hole right down through the stratum corneum layer, and they can live beneath that, close to the dermis, where they thrive. There's also some other weird immunoinhibitory mechanism that they possess, which we don't know a heck of a lot about, but somehow they prevent inflammation, or they prevent a cleanup inflammation that is usually generated by the body to kill off these bugs. So they inhibit that somehow. And then if that's not enough, we know from studies of T. rubrum that they also they slow down the basal cells from making new keratinocytes. So they speed down that conveyor belt mechanism. Remember, normally, on about average, the keratinocytes are born and die within about 20 days, and they're pushed from the stratum basale upward, and then they slough off and end up as dust in your house and feed the dust mites. Somehow T. rubrum releases something, and it slows the mechanism way down to maybe 40 days or even slower. Therefore, the fungus don't get pushed out. If you're turning over cells every 20 days and T. rubrum burrows itself in, it's going to be pushed right out by the conveyor belt. So somehow it slows it down, and that's how it stays on there. Okay, let's talk about the most common dermatophyte infection, and that's Tinea Pedis, also known as athlete's foot. Again, it's a dermatophyte infection. You could call it dermatophytosis. This one is isolated, though, usually to the soles of the feet or between the web spaces of the toes. It could be in the hands as well, but if it's in the hands, it has to be on the palmar surface, not the dorsum of the hand or the dorsum of the foot, right? That's Tenia corporis if it gets on that. It's caused by an invasion of one of the dermatophytes, of course. It's typically almost always caused by T. rubrum. But if not T. rubrum, it's going to be one of the other members of the class Trichophytum, or the Trichophytum generis, or that's like the group, the family that it comes from. It could be one of these other ones as well. T. interdigitale typically causes the interdigital form of Tinea Pedis, or T. rubrum typically causes the moccasin type, but they can be switching around as well. Okay, there are some non-dermatophytes that cause this condition. Doesn't happen that often, but Candida, which is a yeast, can do it, and some of these other ones. N. hylinum can do it. Neocystidilium, I won't even say that one. We're not going to worry. I'm not going to hold you to those, but just know that Tinea Pedis is not always caused by T. rubrum. It often presents concomitantly with other dermatophytic infections. So very common, Tinea Pedis occurs with T. manuum as well. So you could have, especially the interdigital type of Tinea Pedis, you could have it extending from in between your fingers right onto the dorsum of your hand. So then you actually have a double type of infection. People with Tinea cruris also tend to have Tinea Pedis as well. We already said it's the most common, didn't we say that? It's the most common dermatophyte infection in the human, fairly uncommon in children and females for whatever reason. It needs a really warm environment. It needs no sebaceous glands around to flush it out. Therefore, the soles of the feet and the palms of the hand are perfect, or in between the toes and fingers are perfect for its development. Uncommon in people who don't wear shoes because they don't cook in heat. It needs a nice, warm, moist climate for that to grow and invade the epidermis. People in tropical countries where it's humid and hot all the time, it's very common over there. There are two major types of this. There's really three. I kind of said two. Most of the dermatology books we use, like the board book, there only talks about two. There's the moccasin type and the interdigital type. The moccasin looks like you just are wearing a moccasin, and if you take off the moccasin, the spot where the moccasin used to be is full of erythema and scaly skin and maybe some excoriation going on. Moccasin, as we said, is caused by T. rubrum. Interdigital is right between the toes. And then this vesiculobulbous type, not all authors talk about this, but there are some cases, we'll see one picture of it in a second, where patients, usually on the bottom of their foot, they develop flat-out vesicles instead of scaly lesions, and pustules, and even bullae sometimes. So you have to differentiate it from other causes of just other eczema causes. Okay, each one of these has its own presentation. I think that's beyond the scope of this class, except just the very general appearance. So I'm not going to talk about that. But let's look at some of them. So here's the moccasin type of Tenia Pedis. And I always forget to put a moccasin in here, but I mean, a moccasin is kind of a low-cut slipper. And yeah, that's the moccasin type. He's got some onychomycosis going on, right? Tinea unguium, probably. That's probably the dermatophyte infecting the hard keratin of the nail. You can see kind of an active border, but not really that much. Okay, and again, this one's classically caused by T. rubrum. Here's a Tenia Pedis, the interdigital type, which can't really see that good. It started here, but then he developed the old ringworm look, and so that is not. You really shouldn't call that this Tenia Pedis by itself, because this is a body tissue. So this is Tenia corporis, which has occurred here. He has an interdigital Tenia Pedis as well going on, but the diagnosis would be Tenia Pedis and Tenia corporis. And the treatments can be different for both of these. So you might have to put a different type of ointment on between the toes and a different one on the back, and we're not going to get that deep into the treatment, again, beyond the scope of this course. How do you know this is the Tenia corporis? How do you know it's a dermatophyte? Because it's got that weird active border. See, the lesions are worse. They're even excoriated, or almost like little scabs or crusty looking here. And then this looks like it's kind of healing up. So this is the active border. It would be moving too. It would be going this way if it's not controlled. Here's no doubt about this. This is the interdigital presentation of this condition. And yeah, scaly, erythemic, really itchy. It can burn. I mean, this can crack and get infected sometimes. Very common condition. Very treatable, though. What about a predisposition for this thing? So some believe there's a genetic connection by these things. If mom and dad have a problem, chances are you'll have a problem with them as well. People who are immunocompromised, like people with AIDS, or people who have, let's say, a liver, kidney transplant, heart transplant, and they have to take immunosuppressant medication, which suppresses the immune system, much more common, or much higher chance of contracting Tenia Pedis than the normal human is. There's also many different presentations. So ultimately, some of the medication treats all of the bugs, so you don't really have to worry about culturing it. But if you do get a resistant type, maybe it's a yeast, maybe it's not even a dermatophyte. So ultimately, if you're having trouble with it, you're going to have to get a culture and grow it out on a plate and see what the heck it is, and then you can use the proper treatment for it. I wanted to put this old myth in here. I remember back in my junior high athletic days, we had to wear white socks. I remember the coaches would say, you have to wear this because you're going to get athlete's foot and you're going to spread it around the locker room. This is an old wives' tale. It has nothing to do, there's no truth in the myth that wearing white socks prevents you from getting Tenia Pedis or spreading Tenia Pedis. So take that, Coach Holman. Let's see. So this is a weird presentation. People with Tenia Pedis sometimes tend to get something called 2 feet, 1 hand syndrome. And it's the moccasin type that does this. T. rubrum infection causes moccasin usually. And you literally get an infection of both soles of your feet. So you get moccasin Tenia Pedis in both feet. And then strangely, you get it in one palm but not the other. And then an opposite situation is where you get it in both palms in one sole. So there's like out of the four palmar plantar surfaces, one's always normal, which is very strange. And there's been a lot of research on that and statistically significant, and we don't know why that is. Okay, here's a moccasin type of Tenia Pedis. There's two hand and 1 foot. The other foot wasn't shown, but you can see it's affecting the feet. If you look closely, you can even see an active border. Looks like it's been treated and it's starting to fade away a little bit. But yeah, that's 2 hand, 1 feet. And this one I wanted to show you. It doesn't happen that often, but see the almost the bullae formation? They look like blisters. And then it's erythemic. It's got some scaly stuff. But this is the vesiculobullous type of Tenia Pedis that can also present, and that's treated a different way. There's the interdigital type here, easy. This one almost looks like 2 hand and 2 foot. So that's kind of rare. It looks like a little kind of erythemic and scaly looking here. And this is a little bit, so this is the interdigital type. Maybe we'd have to spread these toes and see. But since this is on the dorsum, this is Tenia manuum, right? Because it's on the dorsum. It's not on the bottom side. So make sure, if I test you on these things, make sure you know the difference between these types. The treatment is basically the same, and usually we'll wipe it out. There's topicals that you can rub on. That's by far the first choice. And then there's some oral antifungal treatments that you can take. That shouldn't be creams. Oral antifungals that you take. The newest class of these antifungal agents is much more effective. We'll look at the names here in a second. Let's take a look at them. So this is the king, I would say, at the time. This is 2019. What is it? It's Turkey Day today. Happy Thanksgiving. It's Turkey Day. So this one, luliconazole, is the king. It's a 1%. Prescription only for now. It's an immunodazole derivative, which is a fungus killer. There's many different types of this. And it kills many different types of not only dermatophytes like T. rubrum, but it also kills candida just in case that's the bug. So it's kind of like using a shotgun to do this. If it doesn't work, then you're going to have to isolate the lesion, culture the lesion, and then there's many other different treatments that I'm not going to get into. Over the counter, if it's not too bad, you can try this Lamisil, which is a 1% terbinafine cream. This is over the counter, twice a day you put on it. And the older medications don't work. This clotrimazole and lotrizone just don't work anymore. Lamisil is better. There's been some non-manufacturer research. What's that mean? Non-manufacturer means we don't want to look at the research who this company who makes this does. We want to look at independent research who doesn't care or not paid off by these people. And one good study showed about 88% effectiveness completely clearing the lesions. It did take 5 to 6 weeks to do it, though, just by using the over-counter. So Lamisil is definitely worth a shot. If it starts getting bad, though, you're going to have to jump over and get the luliconazole cream. Okay, I think is that it? Yep, that's it. Okay, let's continue on with Alopecia areata.